Our next speaker is Commander Joseph Dituri. And Commander Dituri enlisted in the U.S. Navy in 1985, and he served continuously on active service upon various ships and stations where he was involved in every aspect of diving and special operations work, from saturation diving in deep submergence to submersible design and clearance diving. Joseph is the author of numerous diver training manuals, a co-author of the book, The Tao of Survival Underwater, and has been published in several journals. His talk will include a provocative exploration and discussion on the use of water, recompression for the treatment of decompression sickness for divers in more remote locations. Welcome, Commander Joe Dituri.
Joe, thank you.
Thanks.
I appreciate it. All right, so unfortunately there are many errors in this presentation already, and I've recognized it by watching a couple now, so just bear with me as we go. I thought this was a CME lecture, so I put my income stuff up here. Apologize. So I'm a former and retired special operations officer, as he said. I do derive income from that. That was me about that long ago. And I sit on the special committee for the American Bureau of Shipping for undersea systems and hyperbaric vehicles. I'm also a one-atmosphere suit pilot. My number is 21. There are 35 in the world. I got the honor to fly that and set up that for the U.S. Navy, and what a great time. I'm a clinic director for the Undersea Oxygen Clinic, and I do clinical research there in hyperbaric medicine. I derive income from that. I have a master's in astronautical engineering, a PhD in biomedical engineering. I'm assistant professor of medicine at the University of South Florida, and I also am adjunct over at the biomedical engineering department, just for grins and giggles. Incidentally, I'm on the 100-day Neptune undersea mission. We intend to shatter the world record, which is 73 days spent living underwater. We're going to break that in great detail up to 100 straight days. And hopefully with some of the assistance from some of the physicians and practitioners in this room, we'll get some of the medical care going, because I got so many questions. So basically, my life's been fun meter pegged way over in the red. Bottom line up front on the lecture, this is not to educate you on how to do in-water recompression. I'm not suggesting it at this point. I'm just giving you the options and the discussion points on it. It is considered emergency first aid, and don't go, well, Joe said in a lecture one time at one place when, it was too cold to dive outside, But bottom line is, I'm not looking to replace medical care. I am looking to insert something which we've had on the books for years and years and years, and then we decided to change things and make it more towards the conservative side, and now we can go back a little bit. So bottom line is, when you're done, you have to follow up with a physician knowledgeable in hyperbaric medicine, somebody that knows what the heck they're doing, so that you can make sure to get that person fixed correctly. So here's the why, right? The why we do this is because less than 8% of these people spontaneously get better. So if you have a symptomology, any sign and symptom of decompression sickness, it's not just going to get better. It's like, oh, just take 2 aspirin and call me in the morning. That's not going to work. 70% of the recreational dive profiles progress, and once you have that dense motor function loss, it's hard to come back. And then it's more likely to occur on top of that area the next time that person goes diving. So, and the bottom line is, there's a culture of hiding decompression sickness, like shaming people. Hi, my name's Joe and I've been bent. And everybody's like, wait, what? Seriously, I've been bent several times. There's nothing embarrassing about it, but there is a thought process that there is. So study on decompression sickness, delay in the onset of treatment, mean 5 days, median 2 days, and you see the outcomes, and it's like, holy mackerel, this is real stuff. This is, hemiplegic stuff, paraplegic, quadriplegic even, not high numbers, but geez, what are the percentages? Let's throw the dice. And when it just happens to be your turn in the barrel that day, because, you're the one that came down with it, it's not like there can be an ounce of prevention after the fact. So there are some guidelines in the U.S. Navy manual, which, as they said, I've come out of the U.S., and that Navy manual winds up being the Bible for us. And you see these things, and if the place is far enough away, and if you can't get somebody to treatment, you should consider in-water recompression. But you got to place the person on 100% oxygen. You got to stabilize the person. So there's all kinds of quid pro quos. Now, in the end of this, we're going to get to that. But before we get there, I want to make sure you understand the why of it, right? So the U.S. Navy dive profiles tend to be square, right? The diver goes down, does what he's got to do for work, and then comes back up. Whereas the civilian dive profiles and the technical and extreme rebreather divers, they go up, they go down, they go up, they go down. I was talking to a bunch of rebreather divers this afternoon, and they're like, oh, yeah, I do all that stuff. So you know who you are. I know. So, but they tend to have some severe paralytic type stuff, some, neurological type deficits, if you will. And as of late, I've seen more weird decompression sickness problems. It's not just pain. Now, by and large, pain is the first and only real symptom that we see in diving. But, these technical extended range divers, they come up with some really wacky stuff. So the truth about decompressive sickness, we think that it's a bubble that's lodged somewhere, and I'll be honest with you, that's a complete oversimplification. I'll talk to you a little bit about it, but I'd like to recount this story that I was told by Bill Hamilton. Bill Hamilton was arguably the father, the 800-pound silverback gorilla of diving research, and he said, Joe, you can ask a layperson on the street what causes DCS, and he'd say, I don't know, I think it has something to do with bubbles. And then you ask maybe a dive master or, an instructor, and they'll tell you about, shaking up a soda bottle, opening it up too quick, the bubbles coming out of solution, and that being the insult, and that's what causes your decompression sickness. Or you talk to a physician that's taken a course, that somebody's taught that's pretty knowledgeable, and they'll talk to you about, popping into solution, Henry's Law, phagocytes, leukocytes, endothelium lining stripping, basement membrane leaking, and the vasoconstriction that comes from that, and the edema, and all the, hypoxia that goes downstream. And well, that's really a good explanation in the most current theory. Then you ask the top 5 researchers in the world, say, hey, what causes decompression sickness? And they say, I don't know. I think it has something to do with bubbles. So. And it's true because everybody runs down the road of this is what causes that. And okay, hold on a second, back up. Let's get some proof on that. But it's the complement system reaction. So now I'm a researcher. Before I was just a Navy spec ops sort of a diver. The immune system is certainly at play here. We can see this histamine response like a bee sting sort of thing. I think that's a pretty good analogy. And that kind of sort of gives you a feel for what's really going on. But it's systemic inflammatory response to a foreign body, right? Okay, so minimizing the risk. PFO is a big thing. 2 in 5 people have a PFO. That's the literature, that's the numbers. That's not my numbers, that's the numbers. 2 in 5, 40, 30, something like that percent, maybe even as low as 25. But that's still quite a fair number in this room. That's a whole lot of PFOs for people that are doing deep diving. Previous DCI event, because we're trying to model scar tissue, and scar tissue is just difficult to model. Age, not for any other reason than the fact that your smooth muscle mediators have been mediated out, if you will, so they don't actually operate very well. Body composition, lean body mass, if you will. We certainly see that adipose tissue is poorly perfused. Therefore, it's kind of sort of one of those things that we tend to get the bends in. Post-dive exercise, all about perfusion. Body temp, perfusion. Sorry, workload of the dive profile is certainly all about perfusion, and then hydration level perfusion. So DCS pain, it comes, it goes, it's all over the place. I kind of wanted to throw this in there just to have a basic slide in case there were people who were just trying to get to the basic understanding of DCS. But it may increase, there's guarding. People will tend to be like, I'm not bent. It's not me, I'm not bent. No, I'm fine. And then they're sitting in the corner. I see a lot of personality changes as well, but the hallmark of DCS is non-pinpoint pain. So it's not something that, if I can point to that spot right there and I say that is where my DCS is, it's probably not DCS, right? So, you hear a lot of things like, I feel heavy, right? I feel heavy, it's testament to, I'm very strained in what I have to do. Mental status changes, you have to know the person well enough. This is, if you are a physician, a practitioner on one of these expeditions, please go do a neuro on them before they get in the water. This way you have a recent relevant knowledge of whether their uvula hangs to the left or not. And you're like, oh, hey, that's a problem. So lots of these things can come up, and urinary retention seems to be one of them. Inability to urinate, inability to defecate is certainly a big throw. So here's what we did. A bunch of us got together and said, hey, we see the symptomology that we have, and the Navy dive manual says type 1 and type 2 DCS, and really they're neither specific nor increasing in range, nor, and you look at these symptoms and you go, God, they were all over the place. And it's like, I got 3 in type 1, and then I got nothing in type 2 that's really explaining anything. So we started to rearrange these things in symptoms, in tiers of symptoms. And what we said was, okay, the first ones always come on due to every diving accident. The second one come on following that. And it's just an ex post facto. We just threw a whole bunch of stuff together and said, all right, here's the way we think it's going to go. And it talks a little bit to tempo and time and the management thereof. So listen, knowledge, right? If you see somebody post-dive that has headache, lethargy, nausea, you can say, maybe I should keep an eye on them. Maybe I should liquefy them in some way, shape, or form, not with a blender, but with water. Something that's you can hydrate with anything that's not dextrose-based if you're not sugar-based if you're going to IVs, but if you're looking, just regular straight water is great, or Gatorade. Any isotonic solution's fine. But you also can see that headache, lethargy, and nausea are something that you can get from, I woke up early this morning, I have a headache, I'm on a boat and I'm nauseous because I'm rocking all over the place. So these are not specific symptoms, and you could just have them, low sensitivity, if you will. But when you trace back all the DCS that we've seen as of late, you go back to the beginning, and the person's like, well, the first thing that happened was I got a sharp headache, or I got a dull headache, or I was so lethargic, right? So those type things keep coming up, and we're like, okay, let's point back and do the initial recognition of symptoms and then move forward. Okay, tier 2 type symptoms, these are moderate severity and specificity, so lymphatic DCS, we do see bilateral swelling, we may see one side, lymph nodes swelling, the entire arm swelling, the entire leg, just the lymph nodes in the groin, wherever, musculoskeletal pain, this is the hallmark of DCS, we kind of breached this a little bit, non-specific, cannot point to it, it's kind of, when you talk to somebody, they'll be like, it's kind of in here, or it's kind of in here, I can't really point exactly to it. So to me, that's the telltale. And remember, obviously you guys know all this, but anytime you think pain, think OPQ-RST. The onset, provocative symptoms, the quality of pain, radiation or radicular in nature, and the time, and like a temporal component to it. Getting worse, getting better on a scale of 1 to 10, where you at? Generalized rash, peau d'orange, cutis marmorata. This may or may not have pitting edema in it. We see this quite frequently. We kind of nicknamed it adipose bends or fat bends because women get it in the hips and the breasts, and men get it in the gut and the butt. So it's just weird, but that's just the way that it goes. And then subjective sensory changes. So those are all tier 2, right? Seems pretty straightforward, but then you get to the tier 3 stuff and you go, oh boy, this is some real stuff. This is bad actors, right? Changes in consciousness, obvious confusion, difficulty with speech, walking imbalance. By the way, don't ever overlook the gait. Like, you can tell a lot by the gait, especially for diving type accidents. Sensory loss, weakness, paralysis. By the way, the weakness and paralysis is in the upper 10% of my strength if I'm the diver, right? So that means when you're doing that neurological assessment and you're looking for 5x5 or 5x4, and you're like 110 pounds soaking wet, like Shauna. Is Shauna in here? All right, like Dr. Pandya is one of my friends, and she tries to hang on my arms. I'm like, okay, you're gonna need more weight than that. But it's in the upper 10% of that person's strength. Here we go, bladder dysfunction, sphincter dysfunction, inability to urinate, defecate, lost coordination of the limbs, and relative shortness of breath. So this is everything on tier 3 is immediacy of care. It's like, look, This has gone from bad to worse, and they very likely, maybe they haven't seen that they had a headache to start with and then stumbled into a little bit of pain, and now they've progressed to tier 3 symptoms. So if you're looking for it, if you're a physician, you're a practitioner, you're out on one of these expeditions, you can be looking for these type symptoms to creep and crawl along, and hopefully you can avert something catastrophic from going on. So what do you do? The definitive care for decompression sickness has been and always is, to this day, pressure and oxygen. Why? You increase the off-gassing gradient to 100%, and you supposedly shrink the bubble. Now, these bubbles grow with respect to Henry's law, and I'm not talking about arterial gas embolism bubbles. I'm not talking about those that grow with respect to Boyle's law, right? I'm talking about strict DCS, right? So these DCS, they grow with respect to Henry's law, and if you read bubble nucleation stuff and all of Eric Megan's paper, it takes a great deal to form that kind of a bubble, and that pressure is so intense that very likely you're not going to be able to crush those bubbles back down unless you go way deeper than the dive that you were on where you formed the bubbles. So just keep that with a grain of salt. So the option here is, if we're in a remote place, we're 24 hours away, and or we have tier 3 symptoms, we're looking at trying to put this person back in the water. Wait a minute. Before you put a person back in the water, man, put them on surface O2, see what happens, right? Hydrate them, see what happens. Obviously never an alcohol solution, IV fluid, enact your emergency action plan. If you're a practitioner on site and you don't have one, shame on you. I suspect all of you already do before you get out there, but it's one of those things that people kind of overlook. They go, yeah, where is the nearest chamber? So one of those you ought to know beforehand. And then look about medevac and air evacuation and so forth. All right. So you have to do a differential diagnosis on a bunch of these things. Remember, I'm a 55-year-old male. So a 55-year-old male experiencing left arm pain. We got to kind of look, okay, you might be having a stroke, you might be having a heart attack. Let's rule that out first. Not that the oxygen won't help you, but in-water recompression in the middle of a stroke or in-water recompression in the middle of an MI, probably not such a good thing. So, especially if you're remote. So tempo, always look at tempo. Keep that in the back of your mind. How's the progression? Where has it gone from? On a scale of 1 to 10, what was it 10 minutes ago? What is it now? All right? So, all right, patterns. Oh, by the way, everybody's like, what are the patterns? What are the patterns? I'm like, the greatest thing in the world is it skips all over the place. It jumps to multiple neuropathies, to pain, to, I just feel funny. Oh, I'm achy. I don't remember what I had for breakfast. So great news is it's all over the place. So that kind of stinks for us from a diagnostician standpoint, but. And there is a bunch of contraindications, because some of the stuff that we're doing out here, you're talking about putting somebody back into the water, and you go, I need a list. So here's your list. I threw together by the way, this doesn't come from me. We had an in-water recompression symposium. It was myself, Simon Mitchell, Craig Jenny, Rich Pyle, just a whole bunch of PhDs and MDs, Richard Moon, and we all wrote a consensus statement, and this is largely the speaking of that consensus statement and a little bit of my own opinion thrown in there. Isolated hearing loss, contraindication. Inner ear DCS, inner ear barotrauma. They both present as staggers, right? So they both present, and the person can't effectively upright. So you're going, oh, it's a vestibular process issue, or do they have a bubble in their ear, or do they have a ruptured round window? Like I said, they both present the same, but I guarantee you the person who has inner ear barotrauma is going to be very angry with you when you put them in the water. They're going to let you know right away that you have messed up. So vertigo, same reason. Obviously, frothy sputum, coughing up blood, issues, compromised airway, right? Altered consciousness, right? If they're not capable of assuming the responsibility of going in the water, that's certainly a bad thing. And if they can't be a safe diver, certainly not a good thing. Hemodynamic instability and CPR. Why? Discretion is a better part of valor? I don't know. We're throwing this against the wall. We don't really know. But remember, you're talking about throwing somebody back in the water. So I ruled it out. You don't have to, but if you make that call, that's a judgment call. Vomiting, compromised airway of sorts, suspected pulmonary barotrauma. Remember I talked to you about Boyle's law bubbles. So Boyle's law bubbles are really wonky, but you can crush Boyle's law bubbles because they form from Boyle's law. So bronchiobrachioli, alveoli, you blow up an alveoli. Where that gas goes, you have to figure what is going to happen to that person. So mediastinal emphysema, subcutaneous emphysema, pneumothorax, tension pneumothorax, or the worst one, arterial gas embolism. Blood bubbles go back to the arteries, to the heart. First stop the brain, arguably. But relative hypothermia, because there's a point where perfusion comes in, right? And when you're so cold that you can't, that you can't effectively pump blood to your extremities, well, then what are we doing back in the water, right? A history of lost consciousness, obviously not a good thing. So here's that inner ear barotrauma, inner ear DCS. Like I said, trust me when I tell you, this person will absolutely let you know that you have done a bad thing here. But it's one of those differentials. And you really, I mean, maybe you can if you're really good and you can see, you have a clear TM and you can see something on the inside. Maybe that's a thing, but yeah. The inner ear DCS is a problem. I'm going to let you read this because this is quite a compelling statement. Right? Richard Pyle wrote this. So when he said it prevents long-term injury and purportedly saves lives, my name's Joe and I've used this, and I was off several places, but one time at band camp, tough crowd. One time I was off the coast of Oahu, just come up from a 120-meter dive or so. We'd found the new species Prognathodes. Something bad happened on my rebreather. Started coming to the surface. I blew off like 100 feet of deco. And then the safety diver met me at like 200 feet. And yeah, long story short, I get on the boat and I'm like, hey, my right knee kind of hurts. My left knee kind of hurts. All right, guys, when are we getting back in the water? Because, we'd let the safety divers go do a second dive after we did this type thing. And I was like, we got to get back in the water. We got to get back in the water. I don't feel good. Guys, I really don't feel good. And by the time we stopped and anchored, I literally had my wetsuit up to my hips. I had a Steel 72 full of oxygen. I put my face mask on, and I put the reg in, and I fell face first overboard. Now, I woke up, and Jennifer Williams, thank you. Jennifer Williams grabbed me from 30 feet, pulled me over to the 20 foot on the anchor line, breathing 100% oxygen, and by the time the rest of the divers made it in the water, I was alert, I was oriented to 3 spheres, I was like, okay, I got it, here's my plan. I had scribed an entire thing out on the, on the notepad, the underwater notepad, and it was like, I would not have made it to Kuakini Medical Center, not a chance in the world. So, but you got to make this decision. You're putting somebody from a pretty easy environment, back into a rather strange environment, if you will. So theoretical reasons why in-water recompression has not been there. Obviously we talk about the risk of oxygen convulsions. That's certainly a big deal. The risk of additional nitrogen loading. I'll tell you, it's from what we have seen, diving and doing in-water recompression with air or nitrox is not worth it unless you're over 75% oxygen. So that's our anecdotal data. Take that for exactly what it is. The risk of drowning certainly there. The need for the risk of tended divers, thermal considerations, sharks, alligators. Come on, like you could just imagine a scenario like you got the waves and the wind and you're banging up against the boat and bad things are happening. So. You never know if the diver can get to an affected treatment area in time. But like I said, in my case, there was no question. I was not making it. My tempo, and if you watch that stuff, the tempo is very telling of your prognosis. So support for in-water recompression, I'm telling you, anecdotal evidence suggests that it works. So what I did was a study. I took a whole bunch of people and I brought them all down to 100 feet. I checked their Doppler, come back up, checked their BOP, 44 people total, split them into 2 separate groups. One group breathed surface oxygen, the next group went back in the water and breathed 100% oxygen at 20 feet for a period of 20 minutes. So surface oxygen breathed 100% oxygen for an hour. The in-water oxygen group breathed at 20 feet, breathed 100% oxygen for 20 minutes. They both came up. I Dopplered both of them right afterwards, and then 1 hour afterwards. Significantly lower, like an order of magnitude lower bubble score for those on underwater oxygen. So you think to yourself, all right, now back up. Remember I told you about the definition of DCS? It might have something to do with bubbles. So it has to do with the activation of the complement system. So, but if you can break it down to a bubble, there are less bubbles, therefore there's less complement system reaction. I don't know, we're guessing. So just FYI. Considerations, yeah, there's some strong considerations. CNS oxygen toxicity is no joke, right? Because you're at 20 feet on pure O2 or 30 feet on pure O2 and you have a seizure, right? It's not the seizure that killed you, right? It's obviously the drowning thereafter. It's when you take that first sip afterwards, that first sip of water into your lungs afterwards, that's the problem, right? So you got to plan accordingly. There's a ton of logistics that go with it. We're going to try and help you through some of that a little bit. More considerations, if you're trained in the use of oxygen, if you're trained in the use of rebreathers, that would be much better off for the long term. You know, but you have to keep the stricken diver warm and certainly well hydrated because you're in the water for a good period of time and you don't want that person to have decreased perfusion in the face of their already existing, you know, systemic inflammatory response. NOAA has exceptional exposure tables. You guys probably already all know the 1.6 for 45 minutes, and that is the mainstay. That's what we say for nitrox, and you know, 1.6, 45 minutes is good. But the exceptional exposure says 2.0 for 30 minutes. So you can get there, you can do this, it has been done. And you know, we lock out of a submarine at 60 feet. 60 feet, which is 2.81, right? So that's a high partial pressure of oxygen. From there, we excursion up to 30 feet really quickly, but even 30 feet is 1.9, so it's not like this stuff hasn't been done before. There are lots of people that do it, so drowning becomes an issue. Oxygen toxicity, when you have any symptom of a seizure, you just need to stop in-water recompression. This is what the consensus statement says, and it's really true. Because if you come across this thing and you come across somebody that has central nervous system oxygen toxicity, it's not worth it, especially when you're in a remote location. So if they have it, your dive's basically over and you go back on the boat and you just kind of chance it and hydrate them and try and do the best that you can on the surface because it's not worth it. That's only if you have any of the vented, right? So visual disturbances, hearing disturbances, euphoria, nausea, twitching, tingling, irritability, and dizziness, right? Any of those, you definitely, your dive is over, bring them to the surface in 1 to 2 minutes and call it good. So, in the unlikely event they have a seizure, the standby diver should be holding the regulator in the mouth. First of all, you shouldn't be doing this in-water recompression unless you have some sort of a strap to affix the regulator in the mouth or a full face mask, right? Because that's certainly the safest way to do it. But you hold it in there until the seizure abates. Upon stopping of the seizure, you make sure they have an open airway and bring them immediately to the surface. Then effect CPR and all the other stuff that goes with that. Finally, in the unlikely event they lose the regulator, and I know this is contentious, and we can argue about it all day long, but trust me, the 800-pound silverback gorillas have spoken about this. So if they spit the reg, bring them immediately to the surface. I know, Lorenzo spasm, right? I know, bag. I know, Boyle's law. I know it can double. I get it. But this is the lesser of two evils, which is, hey, don't let them take that gasping breath. So there you go. That's the thought. So you can take pictures of this for sure. This is the decision algorithm that we came through, which is, look, if there's sharks, if there's tigers, if there's lions, if there's jellyfish, if you can't put them back in the water because of the wind, the waves, the water. I mean, you got to kind of go through this and make sure. And then you make these decisions based upon this algorithm. Start documenting stuff. The more documentation you have on this, the better it's going to be for us in the end, right? Because we're just trying to collect all this data anyhow, right? Next slide, we go to the back side. and we do a little bit more. We drop in the water first. We still check the affected area. We go down. We're looking for issues or concerns, and then we overweight the diver. We make them just a little bit heavier, just a little bit more, so that I can hold on to them better. They need to be affixed to a line. There's a whole bunch of logistics that go with this, including the fact that you're in the water for a good long period of time. Now, we've done this sliding scale, and we've switched it a little bit, but this is by and large the standard thought process that we have at this point. So it also has how to deal with a seizure up there as well. So there you go. If you haven't been introduced to this, I love it. It's operational risk management, and this is a Navy concept. I'm sure it's not a Navy-only concept, but the U.S. Navy loves this. It's all about the probability and the severity of an event occurring. And you can definitely reduce the probability of something occurring, but you can never reduce the severity. So for instance, a great white shark rips your leg off. I know, I'm dramatic, and I'm picking on sharks. They're not quite as bad as everybody thinks. But you know, you're not going to reduce the severity of that. But maybe you can get in a cage, and that will definitely reduce the probability, right? I mean, I know we're all adventurous here, but you know, for instance, the example here is you got swift current, get in it slack tide. You know, I mean, there's ways around it. There's ways to risk mitigate, right? But when you're doing an expedition, could you imagine if you had everything pre-thought of on this sheet, and you can go, okay, here's how we mitigate the possibilities of these things happening, and then we reduce the risk by the overall reduction in risk on the sheet. I made a nice diving neurologic checklist, and you guys certainly can take a picture of this. I can tell you this, that if they're oriented to person, place, and time, and they can state the situation, I stop mental status. I no longer do mental after that, right? You're going to have to talk to them the whole time anyway while you're doing the neuro. Like I said, the gait is something you definitely don't want to miss. Heel toe, easy. Romberg, normal, and you know, they're pointing towards the deficit. Just make sure their eyes are closed, their feet are together, and they're going to point towards their deficit in the unlikely event they have one. The finger to nose and the heel shin slide. So this is, med school students tend to miss this. This is all about intention tremor, right? So both heel shin slide and finger to nose, right? So the finger to nose has to be at their fullest extension. So if you're doing this, that's not going to cut it. Has to be finger to full extension. What you're looking for is that intention tremor. They're trying to find that. Same thing with the heel shin, right? They'll be bonk, 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 bonk. They'll be missing it, right? Because a normal heel shin slide is straight down without a problem, and it doesn't bump, and it doesn't jump, and it doesn't jump around. But those are all intention tremors. That's exactly what you're looking for there. Heel shin slide, rapid alternating hand movement. Sure, you know, they're pretty straightforward. All right, cranial nerves, you walk through these by and large. If you have ringing in your ears, you know, facial muscles, symmetric, you know, we go through all of them in pretty easy fashion, but it's gross. We're looking for gross stuff at this point. Then you progress to strength. You know, you start at the top, work your way down. You find your own flow when you do your neuros. It's okay. This whole thing shouldn't take you but 5 minutes. If you can work through this in some way, shape, or form in 5 minutes, or take pictures of it, and you'll catch by and large like 95% of all the deficits that come out of diving-related stuff. So, you know, right upper extremity, sensory. So in sensory, I understand that where the dermatomes run. I understand how we're testing the dermatome straight down, but then around the extremities. You don't have to bother doing that. Gross, right? Grab them, slide. You feel all that? Does it all feel the same? You feel all that? Does it all feel the same, right? You're looking for gross missing, you know? Tenets for overcoming them, okay? Get the diver warm, because that is definitely a problem. Maintain adequate levels of hydration. Don't undervalue that. So hydrate as much as you possibly can. These people, I believe there is something known as hyperbulimia. I get that, but realistically, there's not a lot of that going on, especially in a dehydrated, person who has decompression sickness. Lay the victim supine. So Trendelenburg with the added left side low. Please don't use that. I realized that was on all the PADI cards, about 1 million years ago. But if you lay left side low, you're just opening it up for a back problem, and then you don't know whether it's comes from the the board, the stretcher, or the fact that they actually have DCS. So, but just treat for shock, right? Lay supine, lift the legs a little bit if you want, but please don't lay them left side low. All right, more tenets for overcoming. Looking at increasing the pressure to reduce that bubble size, but remember that if it is formed with respect to Henry's law, you're going to need a lot of compression to get there. And we're not talking about going that deep when it comes to this. So if you do have a chamber in place and you can go deep, you can effectively crush the bubble, but it's something you need to talk about. Okay, oxygenate the bubble. You increase that off-gassing gradient to 100%, and that insult is made of 100% nitrogen, and now your body wants to be at homeostasis, right? So it's going to absorb oxygen, metabolize oxygen, use oxygen, replace all the nitrogen in the blood with oxygen, and then before you know it, it's going to come out of the tissues, and that bubble will reabsorb. I mean, that's the true way to get rid of it, right? And the tenet of hyperbaric medicine is that if we can get enough pressure on you, then I can get hemoglobin is normally transporting oxygen, then I can get plasma to transport sufficient amount of oxygen to support cellular respiration. It's like, holy mackerel. I can get past the ischemia. I can get past all that vasoconstriction. I can get into that hypoxia. I can work my way into the long, deep tissues that are far away and poorly perfused, even in the face of poor perfusion. I can have increased or enhanced diffusion, if you will. Okay. Consider risk-benefit and the cost-benefit on all those things. Make sure that you have an adequate pre-checklist. I mean, talk to some of the divers. There's some pretty savvy people out there when it comes to, hey, we're going to go do this type dive. You're going to come along as a doc. Ask them what they can experience, what they can expect, what you can expect. So rebreathers are an invaluable tool. That is my opinion. There you go. With that, I'd love to take questions. I don't know how far I am.
Yeah, we do. We have time.
Quote, perfect.
Great. Actually, I'm thinking next year we need to move your talk to the first day, maybe first thing in the morning. I attended my first rugby match yesterday on TV, okay. And there were, despite really aggressive hydration, there seemed to be a lot of people with tier 3 DCI. This would have been really helpful information. And then today, there seemed to be a fair amount with tier 1 symptoms.
Headache, lethargy, nausea, it's post-lunch.
Yeah, yeah.
I realize I'm here, that's why I'm trying to be a little more
I'm blaming
like
it on the vegan
jokes.
cheese. I'm blaming it on the vegan cheese, but yeah. So we do have some questions. Do we have any questions first from our live delegates here? You guys are a shy group. We do have a question. Aaron.
Thank you for that talk. Just with the in-water recompression that you experienced yourself, how long did you stay underwater for, and how on earth did you keep warm for that length of time?
Yeah, so it's hard. The answer is it's really difficult because now you're not even moving, right? You're on 100% oxygen. You're at anywhere. You're at, by and large 25 feet. You're staying for I think the time is like an hour and a half or 2 hours, 2.5 hours, whatever the total time was. You need to get in the dry suit if you possibly can, or you need to wetsuit up and then keep charging it with hot water if that's possible. If you can get a hot water line on the engine and pump that down to the person as an exhale or as an exhaust, that would be freaking fabulous. But, hydration and warmth are two real big problems. I mean, I've tried to drink underwater. Talk about almost drowning. Oh, boy. It's not easy. It's like I can barely drink on stage, much less try and drink underwater. So, yeah, it's if it was easy, everybody'd be doing it. Yes, sir.
Come on, guys. Don't be shy. You have a question. I know it. I'm going to move to our virtual delegates. Any question? We do have a question here.
Thanks. I guess it's stupid, but I will go ahead and ask it anyhow. Trying to secure an airway with an unconscious person and getting him down. Ever tried?
Yeah, so no, haven't. The whole Thai cave rescue diver situation, that was insane. And we were literally all in like a VTC, a video teleconference room, and we were talking this thing through. Because the US delegates were gonna go, the UK delegates were gonna go. We were all like, hey, you're an expert. And we're all, and they're like, hey, I got an idea. Why don't we do this? And I'm like, what the? No, that's crazy. So you can't, somebody with an unprotected airway, it's problematic to put them in the water at very best. So, but in that Thai cave diving situation, that was slightly different. But in order to, you can't put somebody in the water like that. That's one of the obvious consciousness. Loss in obvious consciousness is probably one of those disqualifiers for me. Like, you just can't put them in the water. You know, I know it stinks, and they'll probably spontaneously get better if you could pressurize them. But, you know, that's one of those risk benefits, right? You don't want to take that on yourself. So.
Yeah, I guess like BPAP is kind of a solution if someone is almost conscious.
Now we are fine lining it. The answer is I would personally take every case on a case-by-case basis, and you know, I'll be like, are you able to breathe or not? If you can answer that question, I will put you back in the water. But I need you to make a conscious decision that you're going to get back in the water. Remember, it's a violent environment. There are sharks in there for crying, and jellyfish, which is probably worse than sharks, right? So we're talking about, you know, an environment that's really possibly catastrophic and could kill you worse than you breathing on the surface and dying a slow, miserable death. So choose your way of death, you know.
We have a question in the back.
Uh-oh. That's trouble right there.
Is this a plant?
Hold
No,
on.
not at all.
Okay.
No. And this might be a stupid question too. My question is, how long would you lay someone down on oxygen before you decided, like if they're sort of plateauing and not getting better on oxygen, what would be the time frame that you would call it and consider the in-water?
Yeah,
you might
so,
have answered that, but.
No, that's actually a great question. So it's 1 hour, but trust me, it's going to take you a long time to put together the logistics to get this. Another diver in the water, adequate, wetsuit type thing. You know, can we do this? What's the weather like? What's the jellyfish situation like? It's going to take you an hour plus to do that. So you do the initial 5-minute neuro, and then every 15 minutes you do a round of vitals on them and another neuro, and you're looking for tempo, right? So if you're seeing tempo and they're getting worse, okay, now you got to do something pretty quick before they get to the point where you can't put them in the water. If they're getting better, Jesus, don't break it if it's not, don't fix it if it's not broken, for crying out loud, right? So that would be my opinion if they are getting better. But what we're looking at staving off the tissue, the fact that you can have DCS type tissue, and that's really hard later on. An insult in one area, I always get it in the shoulder now. It's like, yep, left shoulder. Oh, yeah, that hurts. Yeah, that's right. I can't put it behind my back. Put your hands behind your back. Officer, I just can't. They don't like that.
Any more live delegate questions?
Did I answer your question? Yeah.
I do have a couple of virtual delegates that have some questions as well. And the first is that you mentioned the role of the immune system and its role in DCI, DCS. Do you know, is there any role for administration of steroids for tempering those
Dexamethasone is a possibility. If you're going to administer steroids, administer them very, very, very early in the onset, like immediately upon surfacing, immediately upon the suspicion and the initial neuro. Do it then. If you don't do it then, it's the efficacy goes down ridiculously. So, the efficacy is, yes.
Great. We have a question here as well.
When you were talking about the mechanisms of DCS, we think it's general inflammation of the body to a foreign body inside. How come, and we don't think it's as simple as bubbles forming and lodging themselves. How come then when you pressurize someone, many of the symptoms do go away? How does that tie into what we think might be happening?
So it's all about suppressing the cytokines, right? The myokines, right? Whatever. Mm-hmm. So what you're doing is you're pressing the oxygen into the plasma. The plasma is now weeping through the vasoconstriction and the hypoxia downstream, and it's affecting the area that's hypoxic currently, right? So that's making you feel better initially, and then there's a reduction in interleukin-6, right? So interleukin-6, pro-inflammatory cytokine, right? So you're trying to like squelch this whole overreaction thing that we have going on. So the
recompression squelches the overreaction thing.
Yeah, it's your body's overreaction. It's Joe's opinion is your body's overreaction. It's not a full statement of fact, I'm sure.
Great. And we do have time for one more question if we have someone in the live delegation here. If not, I have a virtual question to ask.
Yeah.
And that question is a great one, which is, what's the next step to validate this process of in-water decompression?
Oh, yeah. The problem is I've gone to institutional review boards and they just go, you want to do what? Then no. But see, this is the thing. You know, Efrati, if you guys know the researcher, Shea Efrati, he's a terrific researcher, but, you know, he's in Israel. And that's not a thing for them. It's not a big deal, you know. Like, they allowed him to have 17% cataracts in his last anti-aging study on hyperbaric oxygen. That was just fine, you know. So, like, I can't get it through an IRB here. So if somebody knows an IRB that's very friendly of risk-taking, I'd be glad to go ahead and push that down the pipe. But, you know, the bottom line is we're changing the delivery method of pressure, not the fact that you're getting pressure. You're getting pressure, you're getting oxygen. That's the definitive cure for decompression sickness. How you're getting that oxygen or how you're getting that pressure is, you know, maybe a little sketchy, you know. Come on, you guys have done sketchy stuff. Come on, I'm looking at this delegation going, yeah. I want to do a shameless plug, I'm sorry. I'm signing books upstairs. I wrote a thriller, so if you guys want to read that, that's fine. I have another lecture tomorrow. It's not at 1:15, yet another era. It's at 3, and I'll be up in the exhibitor area if you want any more questions or if you have any more questions for me.
Great, thank you, Joe.
Thank you. Thank you all.
And so for those of you who want to give a talk next year, I have 2 ideas. One is non-invasive positive pressure ventilation underwater would be a great topic. And then the second would be the role of interleukin-6 in great white shark attacks. I think there's 2 I'm giving those to you for free. For free. You can join us next year to give your own presentation. So we do have a minute or 2 before our next speaker. So I'm going to give some time for people to transition. And then we'll resume in about